Gotcha. Okay.
So,
Yeah.
so for infective endocarditis, most commonly to be right side or left side of the heart.
Right side.
What's the most common valve to be affected?
Uh, mitral.
Mitral is in the left
That's
side.
rheumatic fever. Tricuspid. Sorry. I was thinking of rheumatic fever.
Yeah.
Yeah, tricuspid.
So rheumatic fevers, the most common ones are the ones in the left side. Mitral is
Yeah.
first, and then the aortic one. Great. Okay. So clinical presentation, if it was a right-sided cause, like or right-sided infective endocarditis, it's due to IV drug abuse mainly, because it's
Hmm.
intravenous into the heart, and it would be causing septic pulmonary infections because the left side is pushing blood to the pulmonary or the lung. So it would be spreading those infectious bacteria into the lungs, causing embolism. Embolism would be causing infection. So it's pulmonary infection, but a septic infection because it's a bacteria doing it.
Yeah.
Yeah. If
Gotcha.
it's left-sided, it would be emboli all over the arteries. It could be causing something called mycotic aneurysm. We have covered it very well, I believe, right?
Yeah.
And this aneurysm could, after its dilatation, as a complication to this aneurysm, we could have intracerebral hemorrhage or hemorrhage in any side of the body, but the most dangerous one is the intracranial one. Okay. So, by the way, is my voice clear?
Yeah. Yeah. Your voice is clear. I hear you just fine.
Great. So, for symptoms, we have major criteria and minor criteria. Most of the symptoms are the minor ones. So this one is minor, anyone, almost any of them is a minor one. Conjunctival and splinter hemorrhage, like this. Splinter hemorrhage, when we have a multiple choice question and it's a splinter hemorrhage, it's almost always infective endocarditis. But to follow evidence-based medicine, it's a minor criteria. It's not enough to
Gotcha.
diagnosing it, but it would be helping in
For the
exam.
most part, for questions. Yeah. Gotcha.
Yeah. Janway lesion, something, a lesion like macules. Macule is something that's not elevated on the skin. It's just a discoloration
Yeah.
of the skin. That's the definition
Hmm.
of macule. So in the palms and sole, palm and sole, it's called Janway lesion, and it's non-tender. You have to know very well it's not tender. We have two things.
No.
We have Janway for the palm, Janway for the palm, and we have something else called osler.
Osternodes.
Osler's nodules. Yeah, it's in the fingers.
Hmm.
So osler in the finger. In Arabic, finger is called soba, and it's S and S. So, but I don't have a mnemonic in English. So,
That's fine. I'll remember it that
but I
way.
believe I came up with a good one. It's osler is
Yeah.
painful, so it's finger. So the finger one is painful. It's very high yield question, by the way. And because osler is painful, but Janway is painless or
Non-tender.
non-tender.
Yeah. Hmm.
Okay. So some questions at least it's not a clinically oriented or clinically relevant, but yeah, it's a common question to asking for Janway or osler. Osler is painful. Janway is painless. It's affecting the finger. So we have also immunological phenomena, antibodies reaction. First one is called rose spots. It's not the infectious bacteria itself, but it's an antibodies and autoimmune reaction causing exudative hemorrhagic lesion of the retina. Also glomerulonephritis. It's antigen and antibody catching each other, but when
Oh,
they
gotcha.
flow
Hmm.
over the body, the kidneys like catching them because the kidneys have, it's a porous part of the body. It's filtering everything. So this filter would be catching antigen antibody. So it's an antigen called bacteria, an antibody for it. But while flowing through the blood, the kidney would be filtering it and catching it, which is causing
Yeah, the
glomerulonephrites.
immune complex deposition. Yeah.
Yeah.
We do have like renal diseases on this exam as well, so I am learning about glomerulonephritis. Do you just happen to know by chance like the specific one that's associated, like which like nephrotic or nephritic, or is it just in general everything?
If it's nephritis, then it's nephritic.
Okay, okay.
So it's, it's nephritic, ITIC. It's nephritis, it's inflammation.
Hmm. Hmm.
Nephrotic, by the way, nephrotic has O. In nephritic, the kidney is inflamed, like in this case, it's an immunological reaction causing inflammation. But in nephrotic, it's
Hmm.
not inflamed. It's very porous. It has wide pores, like the O, you know?
Mm. Oh, okay. Yeah, yeah.
If it's inflammation,
Makes
it's
sense.
nephritic. If it's highly porous kidneys, many pores, wide pores, it's nephrotic. Okay.
Okay. Yeah.
Also, we'll be having rheumatoid factor positive. It's an investigation that's
Yeah.
associated with immunological reactions or autoimmune diseases. You have to know osler nodule. It's tender, so it's
Hmm.
finger painful nodule. It's in the fingers, So this patient would, while catching anything, he would be feeling pain. It's also mainly on the palmar side of the finger, not the dorsal one. It's mainly in the palmar side of the finger. Everything fine?
Yeah, yeah. I get it.
Great. And we have subacute bacterial endocarditis prophylaxis. So, subacute bacterial endocarditis is coming from the oral lesion or oral from the mouse. It's living normally inside my mouth. It's normal flora. So
Mhm.
if I'm someone who is susceptible to endocarditis and I'm gonna do dental procedure like dental extraction or something, so I should be doing prophylaxis. So
Yeah.
who is the susceptible ones for bacterial endocarditis and should get prophylaxis? First thing is prosthetic valve material. Prosthetic valve, like it's made of foreign materials, so
Hmm.
it
Hmm.
would be having no immunity. No immunity. So it's highly susceptible to infection. So if someone has prosthetic valve, he should be taking prophylaxis and antibiotic prophylaxis before any dental procedure. Okay.
Okay. Yeah,
Uh,
that makes sense.
okay. Also, previous infective endocarditis. So he is highly
And the
susceptible.
history of it. Yeah.
Yeah. If it's just one attack, he should be taking prophylaxis for the rest of his life. Also, congenital heart disease, but you have to know it very well. Not all congenital heart disease would be needing prophylaxis. Not all, but just cyanotic ones. And to be more specific, so if it's acyanotic, you know the difference between cyanotic and acyanotic?
Yeah, yeah. The bluish coloration.
Yeah,
Yeah. And then like the shunting of it as well.
yeah. So the chanting in cyanotic heart disease is from right to left or left to right?
Shunt cyanotic would be left to right. Sorry, right to left.
Yes,
Because you're pushing yeah, unoxygenated blood into the system.
yes. Pushing venous blood into the arteries, making the patient
Mhm.
blue. Okay.
Yeah.
So if it's cyanotic heart, actually not all cyanotic, unrepaired cyanotic heart disease. So if it's cyanotic and just
Unrepaired.
repaired, then the patient is suffering from nothing.
Hmm.
So it's unrepaired cyanotic heart disease. If it's repaired, then we are fine. But if it's repaired and we have a prosthetic valve, then it would follow under first category. Any prosthetic valve would be needing um, prophylaxis. So if it's
I have a question on it. What congenital heart disease would you not repair? Or would you just be okay with leaving as is?
uh, we are not okay with leaving anything not repaired unless it's mild.
Gotcha. Okay, okay. Yeah, so
But
just so
you
what
would be,
unrepaired cyanotic would not really be seen too often in that case.
yes, exactly,
Okay.
specifically cyanotic ones. But you could be seeing like it's is still a child and he can't get into surgery yet. So we're waiting some time for weight gain for some types of cardiac surgeries. He should be above a
Mm,
certain weight so to be able to handle anesthesia and
yeah,
So yeah,
gotcha.
you would be contacting such types of patients.
Okay, thank you.
You're fine. You're welcome. Uh, but you know, there's something if I'm having a prosthetic valve, and here is a normal heart. There's something called epithelialization. It's like the normal epithelium of the heart is covering the prosthetic valve. So it's no longer a foreign, it's covered with our cells.
Hmm.
This epithelialization takes about 6 months. So if I have a patient that I have repaired his congenital heart disease with a prosthetic valve, but it's more than 6 months after the procedure or after the repair, then we are fine. He doesn't need a prophylaxis, by the way.
Yeah,
But it's less than 6 months, he needs a prophylaxis.
you need it because it's still a foreign object. Okay, gotcha.
Great. Um, if it's a repaired congenital heart disease with residual defect, you know why I'm giving every patient with congenital heart disease, at least the cyanotic ones, a prophylaxis? Because if I'm having a congenital heart disease,
Emboli,
no,
that can
I'll
cause.
tell you. I'll tell you.
Okay.
This graphic tablet deserves every cent. It's great.
Yeah.
So I'm having a cyanotic heart disease. There is a flow of blood, high flow of blood this way.
Hmm.
It's like doing injury of the endothelium of the heart. And
Hmm.
endothelium and the valve, both of them, this and this, the endothelium, are both susceptible to infective endocarditis. Endocarditis is not
Hmm.
just the valves, but it could be the endothelium itself.
Yeah.
So this flow of blood is making it susceptible. So
Is it
if I
weakening it?
repair,
Gotcha.
if
Mhm.
I repair this defect, but I still have little or residual defect, like little defect, then I will be still having flow and having injury, and I will still be needing prophylaxis. You know, sometimes
Gotcha. Okay.
we repair regurg or something, and after repair, the new valves that we have inserted have just little leak. It's
Mhm.
having a little leak. If it's mild, we would be leaving this patient. We wouldn't be
Yeah.
doing further repair,
Doesn't
but we
matter.
would be
Yeah.
giving
Hmm.
him prophylactic treatment.
Okay.
Also, cardiac transplantation patients who are developing valvopathy or any valve problem would be also needing a prophylactic, any valve problem. So we have prosthetic valve, any prosthetic one. We are having any prosthetic valve. We are having previous infective endocarditis, congenital heart disease, specifically certain cyanotic heart diseases, cardiac transplantation patients. Okay. Okay, we have a couple of questions. They
Okay.
were actually answered in the lecture, but I need to test you, and I need you to think loud. I need to know
Okay.
what's your thinking process like, so I could
Yeah.
give you some tips.
Okay. So we have a 30-year-old woman with a history of repaired teratology of hello when she was 5 years old. Okay. So it's yeah, so it's basically already endothelialized or however we said it. Presence for dental extraction. prosthetic patch during her repair surgery that has been asymptomatic since. There's no history of infective endocarditis. The most recent echo during pregnancy 2 years ago showed no residual defects. Which of the following is the most appropriate prophylactic measure to take for this patient? So oral amoxicillin 2 grams 1 hour before dental procedure, IV vancomycin 2 hours before dental. Not B. No antibiotic prophylaxis is necessary. Oral clindamycin 600 milligrams um, before the dental procedure. IV ampicillin 2 grams 30 minutes. So I'm between A and C right now, oral amoxicillin. I know, obviously, I know that in terms of her heart, like there's no, it was what, like 25 years ago, so there's no kind of risk factors in terms of the heart that she would need to get replaced. But um, I could have sworn in our last exam that we just had, we were told that anytime you are having a dental procedure, oh wait, no, sorry. If you are at high risk for a high risk cardiac patient about to get a dental procedure, then you get prophylaxis. If you're at normal, like no risk at all, you can go ahead and just get the dental procedure without prophylaxis. So C.
Yes. What's making here low risk? So what's making here low risk? According to what we have.
I mean the timeline. She's it's timeline has been a long time since she had any kind of cardiac abnormalities. She where is it? The echo is negative, or the echo was negative.
So we have
And
no
she's
residual
never had
defect, and
any.
residual defect would be making us to do prophylaxis. Okay, that's first
Mhm,
part.
mhm.
Also, we have a prosthetic badge, but it's 25 years ago.
Yeah.
Just more than 6 months, then we are fine. So that's why it's need no antibiotic prophylaxis.
Mhm.
Okay.